Thank you, Steen. Ladies and gentlemen, I would like to thank Alzheimer Europe for inviting me to this huge and successful conference. It is a pleasure to be in Copenhagen. I just had a walk to the Little Mermaid, and I can very much recommend the Chinese girls who are there. Alzheimer's disease, as we all know, is a cascade, a very complex cascade of pathological events. It starts from different angles. In the familial cases, in the rare familial cases, mutations in several genes lead to an abnormal cleavage or cutting of a precursor enzyme which produces a form of amyloid which has the potential to clot together. In the more frequent non-familial form, the production of amyloid does not play a role, but the elimination, the removal of amyloid from the brain, both converge in an aggregation of beta amyloid, which has negative effects because the beta amyloid fragment is toxic, which has negative effects on the nerve cells. It leads to the production of tau, as we all know, and at the very end of that cascade, nerve cells will die. They will cease their neurotransmitter production, and this results in brain failure or dementia. So in this cascade, we have upstream events early on, and we have downstream events, late events. Our current treatments are working at the very last stretch of this cascade when nerve cells have gone away, when there is a severe disruption of neurotransmitter systems, and when dementia has already occurred. The novel treatments we are talking about act on much earlier stages of the disease. They address the amyloid production or the removal of amyloid from the brain, and some also address the formation of neurofibrillary tangles. I just see that I don't have the correct presentation. But anyway, can you use the presentation I gave to you, the technicians, this morning? So I'm sorry about this. Let's continue then. So I'll just move to where that's better. That's better. So to start again, the current treatments act at the very final stretch of this cascade, but the novel treatments, the future treatments, they address much earlier events. They try to reduce the production of beta amyloid. Other strategies try to enhance the removal of amyloid from the brain, and some also try to prevent the formation of neurofibrillary tangles within the nerve cells. Now, regarding the reduction of amyloid production, how do we do that? This is done by the inhibition of two enzymes. Normally, in the normal brain, the amyloid precursor, this is that little worm that sits in the membrane, this is cut in two parts by an enzyme called alpha secretase. The two fragments that are generated by this cutting effect are soluble and nothing bad happens. In Alzheimer's disease, two other enzymes are active. One is beta secretase and one is gamma secretase, and sequentially they cut apart the amyloid precursor enzyme at the amyloid precursor at two different sites. One is below the orange part and one is above the orange part. And so the beta amyloid fragment is released into the brain tissue. And this beta amyloid fragment has the propensity to aggregate, to clot together. So what can we do about this? We could try to inhibit the action of these two enzymes. And these drugs that do that are called secretase inhibitors. It's easier to create drugs against beta secretase than against gamma secretase, because gamma secretase has several targets, some of which are vital. So the beta secretase inhibitors are more developed. Now, does it work? Yes, it does. These are data from the Merck company. And they showed that several days of treatment with a beta secretase inhibitor reduces the amyloid concentration measured in the cerebrospinal fluid by about 80%. At this time, there are no clinical data, but I think we can expect that a treatment like of this kind might reduce the progression of Alzheimer's disease. Now, the second strategy tries to enhance the removal of amyloid from the brain. How does that work? Well, it is possible to synthesize antibodies against amyloid. These are injected in a blood vessel. Some of the antibodies enter the brain, and what do the antibodies do in the brain? They flag the amyloid that sits there. Now, in the brain, we have some guys that are very sensitive to flagged objects. So they come about and start scavenging beta amyloid. These cells are called macrophages. And this is the way how the antibodies remove the amyloid. It's through these macrophage activation. Does that work? Yes, it does. We are looking at a recent study with one of these synthetical antibodies. We are looking at 4 patients in a larger trial at the baseline of the treatment, so before the treatment has started. What you see in red and yellow color is amyloid deposits visualized by PET imaging. So there's not much difference between these 4 patients. The patient on the left received placebo, which means no effective treatment. Next right received a low dose, next right a medium dose, and on the right the patient received a high dose. So at the beginning, at baseline, no difference. But after a year, there is a difference. The patient who received placebo, no effective treatment, looks about the same. He has even more amyloid accumulating in the brain, whereas the other 3 patients show that the amyloid in the brain has largely gone. So the antibody is able to remove the amyloid from the brain. And how does that translate into clinical effects? You may have seen the same image in a symposium earlier today. These are the dosages, including placebo, from left to right. After 6 months, there's not a great difference, not a big difference between these 4 groups or 5 groups. The bars show the amount of clinical worsening. But after a year, the amount of deterioration is much less in patients who received the highest dose than in the patient who had no effective treatment. And this is a very significant clinical effect. It means that the antibody treatment slows down the worsening of symptoms. It slows down the progression of Alzheimer's disease. And this is a good thing, of course. Here's data from a study with another antibody, which shows exactly the same thing. Both groups in that study, those who received the antibody treatment, this is the green line, and those who received the placebo treatment, the blue line, both deteriorate. But the degree of deterioration after about 1 year of treatment is much less in the treated patients than in the non-treated patients or in the non-effectively treated patients. And the difference is about 30% for cognition. It's about 20% or a little less for activities of daily living. So antibody treatment works. Now, this is good news, but what does it mean? Let's look at the natural course. It's just a model. At the natural course of Alzheimer's disease, it goes through 3 phases. In the first phase, there are no symptoms. In the second phase, there's mild cognitive impairment, no dementia. And the third phase, there's severe cognitive impairment or dementia. The natural course is not as straight as here, but this is just a model. Today, currently, the diagnosis is made when people have mild dementia or even later. The treatments that we have today, they affect the symptoms. They delay the progression of symptoms for several months, maybe a year. But after the treatment stops, this advantage is gone, so they don't change the overall progression of the disease. When we combine an early diagnosis and use those treatments that we have discussed, then the diagnosis is made at a stage where people have mild cognitive symptoms or maybe no cognitive symptoms at all using biomarkers. And the amyloid strategies, they change the trajectory of the progression, aiming at a prevention of the final stage of the dementia, which may not be reached during lifetime. So what is good about this? It's good because people have a diagnosis early, so they have a greater awareness of their disease. They can have a greater awareness. They have better coping strategies at their hand. And maybe, as I said, the severe stage of dementia may not be reached in a substantial number of patients. So that's good news. However, there's also a second side to this combination of early diagnosis and disease slowing treatment. We need to learn how to disclose a fatal disease or information about a fatal disease, that the treatment doesn't stop the progression altogether, it just makes it slower. So we need to learn how to disclose the diagnosis to people who are cognitively fit. People will spend more time knowing they have the disease, and so they will need more support, more counseling, and we need to learn how to do this. To summarize, the novel treatments, either anti-amyloid or anti-tau, they will not prevent Alzheimer's disease and they will not stop its progression altogether. The combination of early diagnosis and disease-slowing treatments will create new opportunities, but also new challenges for patients and for us and for the families. The prevalence of severe cognitive impairment or dementia and dependency may be reduced. However, diagnosis, as I said, will be disclosed to individuals with preserved judgment and foresight. Affected individuals will spend more time in mild stages of the disease, but they will live longer with the disease going on. The need of support regarding coping with disease, planning ahead, maintaining activity and participation, resolving conflict, and creating meaning of life will increase. And the importance of non-pharmacological interventions will rise, including what I would call psychotherapy of people with cognitive impairment. So, after more than a century, there may be a late encounter between Alois Alzheimer, representing neuroscience, and Sigmund Freud, representing humanistic psychology. Thank you.